The new name Saudi German Health, huh? صح؟ This is the new name. The family?
Professor Ashish, you may start now.
Yes. I should start now?
Yes.
Should I start now?
Yes.
Okay. Hello, everyone. Good evening. From Saudi German Health, we are welcome all of you, and we are proud to introduce to you today our Professor Max Hyland. Is a professor of maxillofacial surgery from Berlin University in Germany. Our panelists today, Professor Mohsen Abdul Hassan. He is the head of maxillofacial department in SGH Cairo. Also with us, Dr. Muhammad Abu Saud, oral and maxillofacial registrar from SGH Riyadh. Also, our colleague, Dr. Kamal Salim, the oral and maxillofacial surgeon in SGH Jeddah, with also Dr. Ahmed Abdul Wahab, oral and maxillofacial surgeon specialist, SGH Jeddah. And with you, Professor Ibrahim Hashish, the head of maxillofacial surgery in Jeddah. Again, all of you are welcome, and we are very happy to introduce to you Professor Max Hyland. And the topic today is modern dental implantology. Hello, Prof.
Hello, Prof. Hashish. Nice to hear your words. Thank you very much for the nice introduction. Dear colleagues, times are special, so this is the way we have to get in exchange to each other. It's my pleasure to join Saudi German by this way, but it's not the same to visit your country and your hospitals in person, but maybe it will come back. So now I will try to share my screen. Yep. Let's have a look. Here we are. Yes, now it's working. Modern dental implantology is the topic of tonight. And at the end of my presentation, I hope that also in your routine clinical practice, situations like this will not happen again. These are all cases from Germany done by high specialists, but it can happen, but it should not happen. So we want to avoid situations like this, to keep our life easy and to make our patients happy and satisfied. In our department, except the interforaminal implants in the edentulous patient, all implant placements are planned three-dimensionally. Of course, we are a teaching facility, so we have students and residents with us, but of course, the patients and the surgeons at the end benefit from this. Usually, we use an intraoperative guidance for the initial pilot drilling. This is the only thing we do, but I show you later other options how you can use the virtual workflow. And if I do an immediate implant placement, I use just the extraction socket. In all the other cases, I personally prefer an open approach, not the minimally invasive techniques that are also possible. Especially in the lateral maxilla and in the lateral mandible, the advantages of 3D planning are obvious. In the maxilla, of course, you can clearly judge the available bone height. You can look at pathologies of the sinus. Are there any bony septa that makes your way for external sinus floor elevation more difficult, or can you just use short implants? In the lateral mandible, of course, you can clearly visualize the canal of the nerve. Do you need any kind of augmentation? Can you lateralize the nerve? Short implants or implants with oblique platform. This is really hard to judge if you rely only on a panoramic view. So in previous times, we need a stone model of our patients or plaster model. Then we created a RadioPack scanning appliance like a guide. This is not needed anymore, but when we started, it was needed. But what you need still is any kind of 3D data set, like a cone beam scan or a dental CT scan. And then you have to play with this data in terms of segmentation and virtual planning on placement of your implant and prosthetics. And you can do it by yourself, or you do it online in a web meeting like we are at the moment. So when we started with planning of our implants, this was done in previous times on a panoramic view, and you need some markings that you know the magnification factor of your image, that you can clearly judge the available bone, but only in 2 dimensions. If you look at the German guidelines for dental implants, this is still possible and standard. So it's no need to make it 3-dimensionally, but of course it might be very helpful. But here, this is the easiest way of doing any kind of implant planning. And of course, you can make it a little bit more precise, where you put your implant, where you want to have your marking device at the position of the later crown, so you can combine different well-established techniques. And then, of course, the next step, that you use some kind of software to look on your picture and to make some markings on your 2D imaging to get an idea. However, how to transfer it to the surgery, then it's at the end, it remains some kind of freehand. And of course, in a similar way, even with the diameter and the length, and of course, how you have like an orientation, but during surgery, you place your implants freehand. But it's working. The next thing was that you get any kind of drilling help based on 2D imaging. So here you need a drill guide. It's made like a night guard, and you get some markings where you can put your pilot drill, that you get an orientation where the later crown should be positioned. However, it is sometimes really difficult to correlate it with the available bone quantity and quality coming from the 2-dimensional imaging. The next step, and this is even also more than 10 years ago, that we used Denta CT scans before we get the cone beam scans. But at this time, more popular was the Denta CT because it was more available. Then you started 3D planning. And as I said before, initially you needed some kind of radiopaque prosthesis or something intraorally to simulate the later teeth. The software were really very early introduced, where you could import your data set, and then you had a data bank where you can get your information about the implants, and then you could play around how to position your implants in relationship to the later prosthetics. And this is one of the earlier CT-based drill guides to transfer the information from your planning to the patient during surgery. Another way, instead of drill guide, sorry, I don't know what's happening here. Instead of using a drill guide, is to use a navigation system. This is another way, and it was initially developed in Berlin long before me. It was called RoboDent, and you see on the screen of the navigation the implant planning. So the question after planning is how to transfer to the mouth of your patient. You can use your drill guide or you use navigation system. However, nowadays navigation is not popular, but I recently got the information that Noble Biocare was trying to come back to the market with the navigation system again. The principle is that you need something on your patient, that the system knows where your patient is located. And you see this like a star coming out of the mouth of the patient with reflecting bones. And you need the same reflecting device on your drill. And then the system correlates the situation or the position of your patient and the position of the drill. And with this, then you get an orientation, like if you're a pilot or playing on a joystick, whether your entry point is in the correct position, the orientation is in the correct position, and your drill depth is correctly. And all while you are drilling in the mouth of your patient, you have to look on this small screen beside the head of the patient. And when you're correct, then you can start drilling. You get a feedback of the system that now drilling is possible. Very difficult to handle, not easy, but it was 2008 published, long time ago. For this time, it was really a big step forward. Nowadays, we do it more with drill guides. And so the principal workflow is still the same. We have 3D data. We combine the X-ray data with an optical scan. It can be done directly in the mouth of the patient, or you can take a plaster model and digitalize the plaster model. Then you put the information in the software, and then you get out a guide that has to be produced, and you transfer this to surgery. So first step, cone beam scan and any kind of information of the intraoral situation of your patient, and you have to fuse this both. So you match the scans of the CT, cone beam scan, and the digital scan of the intraoral situation, or you digitalize the plaster model of the patient. Because otherwise you have artifacts and you are not completely reliable regarding the accuracy of the dental surfaces. So with this fused data, you can start your planning. You can first plan your prosthetics. Where should be the crown, the position, the size of the crown. And with this on your system, then you put in the bone information below the implant in the middle of the crown. So backward planning. And then you can just look on the CT scans. You see where the implant will be. Do you have sufficient bone around it? Are you happy with the situation? What is about the neighboring tooth roots? And if everything's safe, then you can proceed. So then you need a guide. And if you want to, a guide can have different shapes, but then you transfer the drilling, the position of the drilling, the diameter, and the length of the drill, the depth of the drilling in the guide information. So how to reach this position to come the drill? You can get the CBCT data automatically because of the artifacts. Sometimes it just looks like this. So this is a data set that is not sufficient for implant planning, but it's coming out of our machines if the patient have some metal restorations. So this is everyday life. Then, of course, you can manually make it softer and smoother that everything looks safe. And now you can work on this. But it's, of course, you have to do a lot of work, and no one of us wants to sit in front of the computer. So we want to get this automated be done. So metal restorations can really affect the image quality and can make our virtual life harder. Of course, we see only hard tissues. So soft tissues are not on the cone beam scan available. So this is why we need some kind of segmentation, and we need the fusion with the scan. And then we get a real virtual surface model of the intraoral situation of our patients. So how to get in combination for the cone beam scan the second information? As said before, we can take classic impressions, make a plaster model. We can put the plaster model in the cone beam scan, or we scan the surface of the plaster model, or directly intraorally scanning. At the end, we get a data set of the dental surface of our patient in addition to the cone beam scan. What kind of scanners can we use? In Germany, the right Trios scanner is very popular, so this is really working nicely, for example. So what kind of information do we get? We get more information regarding the shape of the teeth, the color of the teeth, and around the soft tissues. So this is even for the dental technician helpful information. So with this, we have to fuse to register the cone beam scan and the scan of the surfaces. So this can be done automatically, or we can really help a little bit, or we can do it manually. At the end, we need a data set that is a combination of both. And usually nowadays, the systems does it automatically. However, we have to clearly double check, because if we have discrepancies in the fusion, then we can get a problem with our implant placement. So always we have to take care and double check, because if we have a mistake or an inaccuracy, as you can see here, the implant position might change significantly. And if you're close to important structures, this can be really of danger. The next step, when we get our data of the bone and the intraoral situation of our patients, we need the prosthetic planning. And of course, this can be also done digitalized, or we make a classic wax up and digitalize the classic situation. At the end, we import the data set of the final prosthetics as orientation in our planning software, as you can see here. So now we get a virtual wax up of the missing crown. We play around, we know where it is, and at the end we can stand really where our implant should be. However, the very elegant way is then if you even produce your crowns by CAD/CAM solutions. So meaning you get really everything out of the computer and you just put the implant and the rest is coming from CAD/CAM production. But however, as you know, in dental world, this has to be really tricky and accurate, because the dental surfaces are really very individual. So I usually prefer to go there for the classic prosthetic rehabilitation techniques. So when we put our implant, now we have to come to our guide. So the implant is positioned, we know where the crown will be, everything is safe, but we need to get our guide. And usually this is done all automatically, but you have to understand the steps behind. So of course you have to rely on the dental surface. Then you get some windows inside that you can intraoperatively double check the accurate fit of the guide, that it's really down to the dental surfaces. So why do we use these drill guides? What is the advantage at the end? Of course, we want to reduce complications, especially regarding the nerve injury or perforation of the sinuses. Of course, if we have all the information in the drill guide, surgery is much faster. So the patient's comfort is improved because of shorter surgery time. However, we want to be less traumatic because we can use, if adequate, minimal invasive techniques, and we hope that our patients recover faster. And of course, if we get it really exactly transferred, we have the possibility of immediate prosthetic restorations. So what about this flapless surgery? If we don't open the gingiva and we really drill through the guide, through the gingiva in the bone. With this, we need some kind of attached gingiva that we really, when we go through the gingiva, it is still enough attached gingiva left around the implant. We need sufficient bone, because if we go flapless, there's no possibility of bone augmentation. Of course, the gingiva can affect the position of the guide, and we have to really rely on the position of the guide if we go without opening. There are some papers out that the thicker the gingiva is, the better the guide fits and the higher the accuracy of the implant position. Disadvantage of this workflow is It is more expensive. It needs more time for pre-operative planning. We don't have intraoperative flexibility. And of course, if we drill through a guide, we have less tactile feedback to our hand. And of course, we need more space intraorally. How to be guided? As said before, navigation is a little bit demanding, but has some advantages because we can modify our procedure intraoperatively. However, it is quite expensive and time-consuming, the device. If we are using a drill guide to transfer our plan to the mouth of our patient, it is a quite simple in-office procedure. However, intraoperatively, we have no possibility of adaptation. If we don't want to use it, then we do it freehand. That's the alternative. So usually we are using this kind of drill guide, and the support of the drill guide intraorally can be on the teeth, on the bone, on the gingiva, and it can be used alone or additionally with screws and pins fixed, that it's really in the position. What is the information we got in the drill guide? It can be only for the pilot drill. We can use it for the complete preparation of the implant site, and we can even use it for the insertion of the implant through the guide if we want. So the pilot drill usually has no vertical stop if we use a guide like this. If we got the way of implant site preparation, we get a guidance for all our drill steps that we are needing. And if at the end, it's even possible to put the implant through the guide. So for pilot drilling, it is just a hole, and we use our pilot drill. We have the direction and the entry point, and from our planning, we know how deep we can drill at this position. If we go for implant site preparation, then we can get a guidance for all our single drill steps using special drills. They can be for single use, as you can see here. So all the information is in the drill. So we just put it down. We have the adapted depth of drilling and the corresponding diameter. Or we use it with multi-use drills. Then usually we get some devices that we put in the drill guide to adapt the diameter of the drilling. However, here we have to take care about the drilling depth because the guide and the device increase the height. So we have to double check how deep we can drill. And even it is possible to go with special placement heads, the implant through the guide in the bone is the depth that was originally planned. So the support of the drill can be on the teeth, gingiva, bone, with and without screws and pins as before. If we need teeth supported drill guide, as you can see here, of course, we should have some windows to double check the position. Then it's really easy to use. If we get bone supported drill guide, we get an excellent view because we can really see how deep we are drilling. However, we need a huge extended exposure of the bony surface, a huge flap elevation. If we go for gingiva supported drill guides, then it can be minimal invasive. It is fast surgery. However, the position can be a little bit unstable with limited view. So it's a little bit more tricky and more demanding. However, if you then use pins or screws to fix it as a bone supported or gingiva supported, then you're really safe. Then you have all your time and can relax and do step by step in quiet. If we look at the literature, how accurate these guided procedures are, it depends on the remaining teeth of the patient, and depends on how long our drills and the drill sleeves were. And it's around 1 millimeter discrepant and a difference in angulation of around 3 grades. So going now a little bit step by step in detail how you can start with this procedure. Of course, at the beginning, we need clinical findings. We usually do an immediate planning to judge the cost for the patient, because that's even in Germany, they ask first how expensive it will be. Then we do this cone beam scan, the impression or the intraoral scan, if the patient agrees or gets approval for the cost. Then we start the digital planning, and then we use the drill guide for surgery. So as said before, we need a cone beam or CT scan. We need the intraoral information. We prefer the intraoral scanners. It can be done by your dental technician. It's not done by yourself as a doctor, no problem, and you get the data. As you can see here, upper and lower jaw and in the relation, and then every information there. Or you go for the classic impression and you get your plaster models out of it, and then you start with digitalizing the plaster model. Then you have two different ways of proceeding. The first one is you buy your software and you put the software on your own computer and you do everything by yourself. This is one way. I would not recommend to do so because it's very time consuming, and the software surfaces are a little bit, let's say, not so easy to use. As you can see here, then you sit on the weekend or in the evening on your computer and plan your own cases. That's one way. The other way is you have someone who's supporting you. It can be a manufacturer like Medentis who's producing dental implants or anything else. Or even your dental lab is sometimes doing so. That means we have the software not on our own computer, but in the web. So we upload our data to our manufacturer or our industrial partner. And then, of course, we attached all the data. Then, of course, they need some kind of information. At the end, they need to know, and it's open for all implant companies. So it's not limited to only this one from their own company. So here, for example, we need a drill guide for a Straumann implant, the tooth, and how the drill guide should be designed, and the date of surgery, how hurry it should be. Of course, then you order everything, and this is what you get back. You can have like a web meeting if you want to say, you know, I want to double check. And at the end, you get, this is like the planning report. So here you clearly see where the crown will be, where the implant will be, and you see it in all dimensions. So you know exactly for your surgery what will happen. So do you need an internal sinus floor elevation or an external? Do you need bone substitutes? Is it a little bit tricky or is it easy? Everything, and very easy to use. So no problem to make it complicated. And I like this way. We upload the data, they send us a suggestion, we approve or disagree, and then we can proceed. Then you get the drill guide, and then you can proceed with surgery as you planned before. So no problem, easy. And of course, the cost of the drill guide will be charged to the patient. So you don't have any kind of investment in this. So this is a case I really like to show because this shows all the possibilities of this digital workflow. Here, I want to replace the left first molar by an implant, and so at the same time of extraction. Here you see my digital model of the patient. I segmented the tooth and tooth out. Okay, this is what now I want to put my implant exactly where the crown and the roots were, in between the roots at the intra-bony septum, intra-alveolus septum. Then I transfer this information to the guide. As you can see here, as you can see here, and here, this is the situation. This is where I want to put my implant. And this is the clinical situation. Okay, first in this cases is I have to remove the crown because otherwise my drill guide will not fit. So first horizontally cut off the crown, then drill while the roots are still in place. This is the trick because then the drill is really 100% in the correct position. As mentioned before, I use the drill guide only for the first drilling. So you see my drill guide, I make the first drilling, take the drill guide out. And of course, I tell the patient, now I'm using my drill guide, that he knows this position on the bill later on the drill guide. So then I do all the implant drilling while the roots are still in place, because then my drill has really one way to go. No way, I get only one drilling for my implant. When I finish all the implants drilling, I separate the roots. And now it's very tricky to take them out without injuring the bony walls of my socket, especially the buccal wall. So this is a little bit time consuming. So really step by step, I take out all the stuff of the tooth. And at the end, I have only one hole in the depth in the alveolus where my implant will fit. So when I took everything out, then I can decide, yes, my bony walls are still intact. I can put the implant in. At this moment, I decide, after all my drillings. Of course, then I have to put my implant in the correct hole in the middle between the roots. And you see it like this. Whether you put some bone substitute there or nothing, it's a philosophic question. I usually like to put something in to stabilize my hematoma, as you can see here. Then I put like a collagen fleece on top, just fix it a little bit. No flap mobilization, leave everything as it is. This was the planning. This is the X-ray afterwards. And you see, it's not so bad. This is the situation after 4 weeks by normal healing. This is after 6 months, and then went back to the dentist for the crown. Very nicely, all the structures preserved. And you can do this even in the upper jaw, where the tooth has 3 roots, as you can see here, even in combination with the internal sinus floor elevation. Same principle. First, cut off the crown, as you can see here. Drill guide for the pilot drilling. All the implants drilling are done through the tooth. Take care because of the sinus floor here in this case. Separation of the roots. Taking out the roots very carefully. 3 roots, 1 drill for the implant. Put the implant in the correct hole, as deep as you planned before. Some bone substitute, some collagen fleece, and post-operative X-ray. After 4 months, nicely now going for prosthetics. So virtual planning, really, it's very accurate to transfer your plan to your patient, even in these special cases. And if it's working in these cases, it's working even in the normal cases. However, backward planning really offers you much more possibilities, even in very complex cases as in this one. So the principles are always the same. You need 3D data. You need 3D data of the intraoral situation, and you need your prosthetic solution or your prosthetic plan virtually to fuse it with the preoperative situation. Here you can clearly analyze how much bone is needed. This is the wax up of the patient. She was edentulous, so much more demanding. Here you see the virtual situation where we want to end up. And this was a patient where we used the fibula for bony augmentation. You can use iliac crest, whatever you use. But here we are like this one. And you clearly see where it should be positioned, that the implants are in the correct position. And then you can proceed with the prosthetics later on. Everything virtually, as you can see here. And now backward planning. In this case, we transferred this plan to the lower leg to put the implants first in the bone before the bone comes to the mouth. This is really high level, but it's working. And the principles are all the same. So then we took an impression from the lower leg to send the data to the prosthetics. And they started to make our prosthetics. And then second surgery, transfer of the maxilla, the new maxilla to the mouth, including the prosthetics, as you can see here. Resection of the remaining bone, putting the tooth on it, putting the flap, the bridge or the bar, and the teeth, and everything back to intraoral situation. As you can see here, patient after surgery, could smile a little bit more, but nicely done. Nowadays, especially in the very complex situations, there's a new alternative coming from KLS, and it was developed at the university in Hanover. It's a little bit similar to the subperiosteal implants we know from years ago. But here it is the difference, they say, and we started our first own cases, is that the fit is much more accurate and the fixation is done by many, many screws. So there's really no mobility in the device. But of course, this device, this implant is going intraorally. So you have an exposure through the mucous membranes. And this, in my opinion, could be a little bit risky. So this is the first case we did. This patient had this anaplastology rehabilitation, and after 16 years, the retention implants got lost. They got loosened and they will fall out. So we have to redo her again. And this was the situation. And she said, no big surgery. Do it with simple procedures. Not so easy. And so then we were thinking what to do. And as said before, we need the final situation to start with backward planning, coming from the prosthetics, going backwards. What is surgically needed for this? So this is the situation. This is the result we want to end up, and in between there's a gap, and how to fill this gap. And this is done by this patient-specific, let's say, implants, but at the end it's plates, and it's combined with some devices for the dental rehabilitation. And then you can combine this. And this is how it looks in reality. And this was produced, and this was the surgical field. We put it in, and it looks good, right side, left side. We were quite happy, but at the end, the position was not exactly the position that we were planning. Here we got a difference. It was not obvious for us because on the bony surface, it was really fitting nicely. But then we have to adapt our prosthetics, as you can see, because left side was the plan, right side was where we ended. So always have to be critical and don't trust virtual world 100%, because sometimes it is not what you're expecting. Of course, we were here able to adjust it, but it looks a little bit individual, to say so. And this is really my honest result. We did a second case. He had a scapular free flap. He had a huge vascular malformation. So we did some surgeries to reduce it. And then it was like this, but the bone was not sufficient for dental rehabilitation. We don't want to go in with bone again. Same principle again. Start from the prosthetics, going backwards, as you can see here. So we had to, this is the end. So we have to get some space. We have to resect a little bit of the bone. You see many, many screws to fix it really on the bony surface. You need quite exposure. So it's under general anesthesia, usually as an inpatient. And then everything should be possible. You get this virtual plan. You can order it, I think, even from KSA and Egypt. And KLS would be your partner in this situation. Here, intraoral situation, exposure of the bone, guide to get the space. And you see all these holes. These are all pre-drillings that your implant gets exactly the position that is considered. That's what they say. But as you've seen in the first case, sometimes it's not. So here we resect this bone, put the implant on, looks good. As you can see here, adjusted in the vertical relationship to the lower jaw, closure, and this patient is still under prosthetics. It's a very fresh case of us. So, but this is really modern implants, what we do at the moment. But what is the next level? What is coming next? Because we can't change the world, but I believe we will plan our implants on MRI. If you look here, you can clearly identify in normal MRI scans the relevant structures for us, and it's without radiation exposure. So I expect this will be a next big thing in dental implants. If you look, you can clearly do the same way of planning as we've seen before, but here without radiation. And you can use the normal scans of your radiology department. You can import, because it's DICOM data, you can use the same software and put on an MRI scan. However, it's a little bit for us unusual to really identify the bony surface, but at the end, it's working. It's exactly the same. You have to play a little bit, but then it's working. And you can put the same, in the same manner, the implants, and here in an MRI instead of a CT. So with this, I want to end up 45 minutes. I was asked to do so. If we are free to travel again, you're welcome to visit us in Berlin to look at our cases and how we do it. But this is at the edge of dental implant placement in our department. Thank you very much for your attention, and I'm open for questions.
For this amazing and very extremely fruitful talk. Really, we are enjoying it very much. It's great.
Thank
Really,
you.
it's great. Thank you very much. And just to travel with you a little bit, our journey with the implant in maybe particularly in Jeddah, we started with IMZ and the Branamark long time ago,
Yes.
moving by then Stroman for many years. Then before Corona, we moved to the nano implant, the Italian leader, down to 2.3 and 2.7 millimeter. And then during Corona, I found myself and my colleague that because we don't trust the bone substitutes available in the market at that time, because of the problems of traveling, so I prefer to go back to the nano implant, which is OsseoCare, also 2.35 and 2.7, just to avoid to not to use bone substitutes, which as I'm not sure about it, because it is different in the market. But during this journey, to compare with what I have seen, the amazing work of the facial rehabilitation guided work, and with this technology, or whatever, if it is IT technology and the mechanical and technical technology, end up with these results. Really, it's amazing. And I hope one day we can reach to this amazing facial rehabilitation. Thank you very much. And I would like to hear a comment from you. Then I will leave my colleague to ask if they want.
I know the great work you're doing in Jeddah, Prof. Hashish, because I visit you many times. And I can understand the discomfort with bone substitutes because they cannot change the intraoral situation. What I really, and this was, I think, the message of my talk is that even for you, it is of help if you know before you go for surgery that you can use a 3.3, 2.3, 2.8, 3.2 implant, and you can really prepare yourself what to expect. Because if you really have low level of bone, you have only one shot for drilling. And whether you use a cone beam scan or a dental CT scan as your radiology department, I know the imaging, they nicely prepare the exact amount of bone that they demonstrate on the imaging, that you know before what to expect. And of course, if it's possible to avoid augmentation, life is much easier. We know this, and with 3D planning, you know in advance whether you will be successful or you need some bone grafting to support, to improve the bony socket. Yes. But at the end, we have to be a surgeon and to be able to put an implant in the correct position with the correct technique in the bone. That's
we always do that because we do our measurements down to 0.1 of mil. Yani we divide every mil to 10 shots.
Yeah.
So with this care and with nano implants, so we can avoid the bone augmentation or bone substitutes. But this is not will work in all cases. Sometimes we have to rely on bone substitutes. I would like to give the chance to Professor Mohsen from Cairo. If he like to ask a question or comment, please. Professor Mohsen. Okay. So Dr. Muhammad Abu Saud from Riyadh with us. Hello. Type now Dr. Kamal Slim.
Yes, I'm here.
From
Thank
Jeddah.
thank you so much for that very informative webinar. I really enjoyed. It's very fruitful, and I really enjoyed it. I have a question which will take us to a different part of that world of dental implants. It's about the biomaterials. Will take us to the manufacturing. The biomaterials, the new trends in the biomaterials, the surface treatment, and the new modalities in that part, which is important part of the dental implant world. What's new? What's new about that?
Honestly, to say so, of course, some products change their names. Some products, some manufacturers changed because they were sold to other owners. But at the end, the principles still, I think, regarding implant surfaces and regarding the bone substitutes remain more or less the same. I personally, I don't like the synthetic bone substitutes, but of course, many patients are afraid that they got bone substitutes coming from animals, whatever animal it is. And of course, we have to explain to the patient in advance. But in my hands, the regeneration potential, if you use it coming from animals, at the end, they are better than the synthetic ones. But this is my personal feeling. What I see, the new technology that's a little bit helping us further is the PRGF world or PRF world. If we use our blood samples from the patient, we make the centrifugation and we get it liquid or in terms of a membrane. It's a complete philosophy behind, but you get something additionally to support your local healing and your local, let's say, regeneration. And we don't use it only in implants, we use it also in cases of biphosphonate-related necrosis of the jaw, where we have affected wound grounds that need some kind of biological support. So the PRGF or PRF world of getting something of high biological value to support your local regeneration, your local healing, is that what I would consider new. It's not new in terms of months, but less than 10 years. And it's easy to use. And so this is something I would recommend to include in your surgical techniques, but because you will consider it sufficient. And sometimes you can really substitute your artificial membrane, but coming from a membrane from the patient. So you need less biomaterial and more biological material in similar situations. So, but the condition is that you get some experience with this. and it's not so difficult.
Yeah.
Thank you, Prof. Dr. Ahmed Abdul Wahab, you want to add something or you have any question, please, from Jeddah?
Hello.
Yes,
Hello.
yes.
Hello, Prof. Max.
Hello, I can't hear you.
Hello, Prof. Max. It's very grateful, and we miss you so much.
Me too.
Please, Dr. Max, could you please? I want to ask you. I heard before for the zircon material of the implant itself. Could you please, can you tell us you work with this material before or no? And it most osteointegrated than the titanium alloy or the same?
It's the osseointegration is not the problem with the ceramics because they integrate very well, and even you have two advantages. One is that for the patient there's no metal. Some patients, even in Germany, complicated patients, they don't want to get any metal, so you go for ceramics, although it's also a complicated chemical situation, but they prefer the white thing instead of the metal one. So you can put it and it will be osseointegrated. The second advantage is that regarding the soft tissues, it's a little bit more, let's say, more biocompatible.
Yeah.
But you have the problem that the prosthetics can be a little bit more difficult because if you have your one-piece implant, then you really have the correct axis. If you have two pieces, then you have much more pieces that can get problems. And the big problem is in ceramics that they can fracture. And if they fracture, they are destroyed. And if they are destroyed and osseointegrated, you get a big defect to get it out. Titanium implants don't fracture. Yes, they can fracture, but this is really, really an exception. And in ceramics, it can happen. So I personally don't like them because titanium is working. It is very, very well established. All of us have experience, and in our hands, they are safe. If complicated patients want a complicated solution, usually I refer them to a complicated colleague. Don't do it by myself.
Okay, thank you, Prof. Professor Mohsen Abul Hassan, again from Cairo, please. Professor Mohsen. Okay, Dr. Muhammad Abu Saud from Riyadh. Okay. Any question from any audience, please? Okay. So, Prof, thank you very, very much. And it's really, again, it's amazing. It is piece of art you delivered today for us. Thank you very much. And since you just have said before on air that you got the 2 vaccination, so now you should have already the German health passport. So you can visit or start a visit the Middle East after we are ready for you.
I'm counting the days, but I think it will take some days till we are allowed. Even my employee has to allow me to travel.
Yeah. And
I'm ready. I'm ready.
Yes, now it's the regulation is very nicely, really. If you have your health passport, you are going to very good place like SGH German Health in the Middle East. So you most welcome, and by this time all the people already have the 2 vaccination and they are ready to see you.
I hope so. Looking in the future, in the near future, to do so and to see in person again would be my pleasure.
Thank you very much. Thank you very much.
Max, there are a couple of questions from the audience. If you can click on Q&A section on your screen, You can see 2 questions are there.
Yeah, but I think I have to stop my presentation first. Let's do so. Yes. Thank you for a nice presentation. At which age cleft palate can be corrected? Okay, it's not our topic, but no problem. Usually it depends whether it's soft and hard palate together. Usually we start with the soft palate, and it could be done at the age of 6 months or a little bit later, but not before. If it's a narrow cleft, you can correct everything in one step. If it's a huge cleft, soft palate first, wait till a little bit of growing and that the hard palate cleft gets shrinked, and then do the rest. Cost of the presented case, probably the case with the fibula. It's a little bit tricky because not everything has to be paid by the patient privately. The bone augmentation or the bone transfer was paid by health insurance. The prosthetics in Germany, it's around 10,000 to 15,000 euro. It depends on the lab you're working with, but it's an expensive procedure and not for every patient. Mr. Schubert, I think that was the 2 questions, right?
Yes, yes.
Yes. Any more questions?
I think that's all. Professor Hassis, you may conclude the session, I think. We don't have any more questions from the audience.
Okay, thank you very much, Professor Max. Thank you very much for what you did for us and what you delivered today. It is a piece of art, as I have said, and it's amazing work. Thank you very much on behalf of everyone in the Saudi German Health Group.
My
Thank
pleasure.
you.
Thank you.
Bye.
Hope to see you soon. Thank you very much.
Inshallah. Thank you. Thank you.
Bye-bye.
Bye.
Thank you. Bye-bye.
Bye.
Bye-bye.
Bye-bye.
Thank you, Doctor.
Bye.
Thank you, Prof. Bye-bye.
Thank you.